Welcome everyone to the virtual Global Spine Conference. On behalf of my colleagues and co-hosts, Dr. Ali Bash, Dr. Jonathan Rasuli, as well as Dr. Wendy Gibbs, John Shen, and Koi Than, who will hopefully join us later. I welcome my mentor and dear friend, Dr. Tyler Koski, one of the best spine surgeons in the world. He is a director of neurological spinal surgery and also the co-director of the Comprehensive Spine Center at Northwestern Medicine. He's just a supreme surgeon and asset to really the spine surgery community. And without further ado, I'm gonna have Dr. Koski take over and entertain us with one of his supreme presentations.
Thank you, Nader. I very much appreciate that. And thank you all for inviting me to this really impressive conference that you've really set up. And it's been great to see it take off and do so well. I'm going to talk today about just a little bit of my journey through spine surgery and how I think through things, and really about just growing as a surgeon. And hopefully for some of the young surgeons on the call, it gives you a sort of an idea of what to try and do through a career. And you got to find your own path, but this is a little bit of mine. So I do have some disclosures, hopefully not too relevant. We're going to talk about some spinal techniques, but nothing is directly related to any specific company. So when you think about spine surgery, it is a constant process of learning. It seems like when you're in residency and fellowship, you want to be done and go out and practice, but it's just the beginning. You grow from your work with patients. We learn a lot from our colleagues. We have a indications conference that we had this morning. We do every Thursday that I find just great to hear my colleagues talk through cases, and I always learn something from them. Being active in research and keeping up with literature and doing conferences just like this, trying to keep your skills up, learn new techniques, and just learn little nuances from people. It's a never-ending process of getting better, and that's what keeps us at the top of the field. So during my time in neurosurgery, I came into training right at in 2000. So I've been in practice now for 15 years, and lumbar pedicle screws were common. So I didn't go through the hook era in the lumbar spine. I wasn't a Harrington type surgeon, but things that didn't exist and that came along during my time that made really big changes in practice and in what I do. So thoracic pedicle screws, 3-column osteotomies, minimally invasive surgery was in its infancy. So there was a tubular decompression back then, but all the minimally invasive techniques have really taken off. The lateral procedures have really been a huge game changer. And then pelvic parameters and sagittal alignment have been a really big key in understanding how we do well with spine surgery. And we've kind of riding a little bit of a wave where nobody's doing it, then everybody's doing it. Now maybe we're overdoing it, but it's all a part of, those were sort of big game changers that I saw through my practice. And I'm always a believer, if you're not getting better, you're falling behind, right? You need to get better each and every day, certainly each and every year. If you're doing the same thing over and over again, you need to ask, where could I be getting better? So some problems can be complicated. So I show this case is something that, this was when I was in training. This is probably 2005, sitting in a room with Steve Andre, and we had this patient come in. Now, it doesn't look too bad when you just look at it. But if you look at that patient walking in, that's a significant spinal deformity. This is somebody that had a spondylolisthesis, had a short segment fusion, and fractured her sacrum below. And if you look at that yellow line on that X-ray, that's a plumb line from the posterior superior aspect of the sacrum. And when that never touches the spine again, those people, when you see one of those patients walk into your office, it's pretty striking how difficult it is for them to stand, function, and really do anything. So she was 52 years old, so not particularly old, had a spondylolisthesis and did well for a few weeks after surgery, and then had increased pain, had this fracture, and was managed in a brace. Just an aside, if any of you ever see this happen in fractures and you see them, take them back to surgery while you can still fix it, right? If you get it to heal like that, it is really, really bad. So some preoperative studies, you can see that fracture through the sacrum and how the sacrum has now become kyphotic. And if you think about the pelvic incidence, Well, this lady changed her pelvic incidence by fracturing her sacrum and becoming more kyphotic to something that was just not manageable for her to stand and walk. So trying to figure out how to deal with this. Bone quality is certainly an issue if they're fracturing. How do you restore that sagittal balance? Now, this is in the era when 3-column osteotomies were gaining traction. We were doing a lot of pedicle subtraction osteotomies, and we showed this to several different surgeons at some conferences after we'd already taken care of it. And we got a lot of answers to do a L3 PSO, right? Trying to get somebody to be 90 degrees of lumbar lordosis seems a little crazy because that's certainly not anywhere near normal. And then how do you get fixation in this? So a lot of things that factored in. So what we came up with at the time was a sacral osteotomy. We essentially did a pedicle subtraction osteotomy at the S2 level. Now that's not like doing it at the lumbar level. Those are different. The anatomy is different. The sacrum is certainly different than the lumbar vertebral body, and the sacral ala connect out lateral. So how you do that and what you do took a little bit of thinking. And I have very fond memories actually of sitting in this little office that was off of our ICU because Dr. Andre was our medical director, and just brainstorming on what to do and how we're going to cut that and what would that look like. And then to actually go in with him and execute it and make it work was pretty rewarding. But the key is that you do a wedge resection, but you do some sacroalar osteotomies. And then the closure is a pelvic rotation. You're like derotating the pelvis to close that osteotomy, not simply compressing down, which was really key. And there's the artist rendition that we published where it's those alar osteotomies out on the sides that were really important to allow that. Essentially, you took the S1 vertebral body and disconnected it completely from the remainder of the sacrum and the pelvis, and then had to rotate that closed and then reconstruct that pelvic ring. So an intraoperative photo of one of those cases. So if you look in the upper right-hand column, you can see the S1 pedicle screw and this transiliac bar and the large gap between there. And then if you look at the lower left-hand corner, you can see how much closer those screws are together, how much closure there was across there, and that significantly altered that alignment. And if you look at that x-ray there, a pretty impressive change in overall spinal balance just by doing a sacral osteotomy. Didn't do anything other than instrument that lumbar spine. And that's a 6-year follow-up film, and she continues to do well. So if you look at her factors, she had a pelvic incidence that was 88 beforehand, went down to 65. So not a huge numeric change, but the power of being low in the sacrum and pelvis, that makes all the difference there. So if you look at her lumbar lordosis, it went from 68 degrees down to 61. We actually lost some lumbar lordosis, not through our instrumented levels, actually. We lost a little bit probably at the upper lumbar spine, L1, 2, because she didn't have to lean back so hard to try and stand up because she'd stand up naturally. But we actually went from a mismatched pelvic incidence in lumbar lordosis to a matched. And that's really the key. And part of the key to figuring out how to do that back then was that we did that at a time when pelvic incidence became a known phenomenon. That was something we were starting to measure and starting to figure out that correlation. And if we didn't do that, if this was a few years beforehand, we might have done something silly like a pedicle subtraction osteotomy in that lumbar spine, trying to just get her to stand back upright. But understanding the importance of that pelvic incidence was a game changer, and it's still driving the way we practice today. So a few more cases that shows similar techniques. So this was a high-grade spondylolisthesis that was fused in position that the patient had a lot of pain and a lot of sagittal imbalance. This was a difficult one because the sacrum wasn't kyphotic here. So we essentially did this through S1. We said, well, if we could do an S2 osteotomy, why can't we do it through S1? And did that with a good correction. This person did great. Initially developed a foot drop afterwards. So anytime you talk about high-grade spondy, worry about that. So there was the one neurologic deficit, and any of these was the one we did at the S1 level, but still worked out fairly well, and again, corrected those parameters. Here is one that was a really difficult one. This was kind of midway through some of my early cases of these. So this is somebody with spina bifida that was an ambulator and had this lumbar fusion done. I think this was in Texas. And then after the fusion was unable to stand. She simply couldn't stand and walk. And so she was fused with a mismatch of the pelvic incidence and lumbar lordosis. And she has a very high pelvic incidence at baseline. And so she found us through the publication actually, and ended up coming in, and we talked about it, decided to do that same thing. The problem here, and I would caution anybody that tries to duplicate this type of technique, is I always tell our residents and fellows, it's not how much of an osteotomy you cut, it's how much of an osteotomy that you close. So you can cut a really big osteotomy. If you only close it a little bit, you only get a little bit of correction, and you just create a gap that risks pseudoarthrosis. And I had a little bit of that phenomenon here. So she didn't have a kyphosis of her sacrum. So my implants were not really far apart to begin with. So I cut the osteotomy and closed the osteotomy until all my implants touched, and then I was done. So if you look here, everything is touching, all the screws touch. So that's all that I could get. Now she's much better, and she went back to ambulating after that. So that was a victory in and of itself. But I didn't get her back all the way what I had calculated, because I simply didn't have the amount of closure that was necessary. I cut an osteotomy that would have given me enough, and didn't think about the fact that I was going to hit those implants together. And once they did, I had to actually pack a little bit of bone in there to try and get that to heal and fuse. Here's another one, much like that first case. So this is another lumbar fusion, fused down to the sacrum, no iliac fixation, a little bit of bad bone, and a sacral fracture, braced, healed in that position. And if you look again, the difference between where that C7 plumb line and where the posterior superior aspect sacrum are is dramatic, like sagittal balance can always be. But the fact that the spine never touches this line back here is always a little tricky. And the amount of abnormal takeoff of that pelvis is, again, I can pick a patient with this problem walking down the hall. I can see it immediately, and I know it's coming my way.
Hey Tyler, can I ask you a quick question?
Absolutely.
Hey, thanks so much. If you go back to that previous image, and I know a few folks on this, from the participants are probably thinking the same thing. These are obviously challenging surgeries. We do see them once in a while. And I'm interested in sharing with folks how, like you were saying, you and Dr. Andra initially were looking at these. Basically nobody showed you how to do it. You guys had to think about it, draw it, look at it in a model, and then do it. So at some point, we as spine surgeons, we have to just do it. And so, can you just talk a little bit more about that? What advice would you give other surgeons when they see potentially technically challenging cases, and how would you recommend they go about studying the anatomy, playing out the technique and actually doing it, not just saying, well, I can't do this, I have to refer it out every time, because you guys started that way.
Yep. So, I always think when you do complicated things, you got to break it down into its component parts, right? It seems really daunting and overwhelming. You look at the whole picture like, wow, how am I going to do this? But if you break it down to where's the real problem, and in this one, it was just knowing the pelvic incidence and lumbar lordosis relationship, and we could see, wow, there's a big mismatch here. But the lumbar lordosis wasn't the problem; it was the pelvic incidence. And then how would you go about changing that? So for us, it was breaking it down into that component problem and recognizing where the pathology was, and then trying to say, well, how would we treat that? So knowing your anatomy is absolutely crucial. Game planning that out and having a step-by-step plan of what you think you need to do to get that to move, and having a plan when you walk into the operating room that you're going to execute step by step is really, I think, the key to this type of problem in this type of surgery. And then you have to have the confidence to actually do that. So I can tell you, the first time we did that case, when we were going down, resecting the sacrum and doing a sacral osteotomy, not a big deal. Doing that alar osteotomy was a little bit different. So you have to come out lateral to the sacral foramen, and knowing all those structures that are in front, knowing you got iliac vessels in there. And so we kind of drilled down to that cortex, and I always remember just cracking it gently with an osteotome, holding my breath with each of those little cuts, trying to be really careful and cautious. Just people that do on-block sacrectomies and dissect that in the front know exactly what that's like. And right, that's a huge surgery that you really need to know that anatomy. This is similar anatomy. It's a little bit of a blinder shot because you don't get to do any dissection up there because you just don't have access to it. You're just trying to create a small enough gap to get it to rotate, and then doing it cautiously and carefully. So it's rewarding to think through a problem and come up with a solution and get that to work. It really is. And again, this came down to just being at the right time in spine knowledge and skills and implants and everything else to be able to execute and do that.
Excellent. Great. Thanks so much.
Yeah, I just have a couple more of these, but another one showing you again the same thing. I always put a transiliac bar in these because we're cutting and we're disconnecting that sacral ring and just trying to reconstitute that ring. Biomechanically, how necessary is that? I don't know, but I've never tried it without. I know somebody has and has had a failure, but there may have been people that have done that without and done well. for me, it's an extra fixation point. Now I would run additional rods off of there, and it just gives me a stronger construct across that. Sort of the concept of multiple rods across a 3-column osteotomy still applies in this case in my world. Another one is a post-traumatic kyphosis, healed in kyphosis. Again, you can go short segment if it's just the sacrum that you're trying to correct, and that was a young patient. So no infections, no vessel injuries in all of these patients. Well, that 1 foot drop that did get better, but never was fully back to normal. And the improvement in alignment is pretty dramatic in that, so quite rewarding. But not all advancements are coming up with some big, huge, crazy surgery to do. Some of them, and most of them in our world, are incremental. And I like to walk through TLIF, which TLIF is something I do quite a bit of. Everybody has their niche and their nuances and what they like to do. I do quite a bit of TLIF. So when I was training, TLIF was coming in and it looked just like this. This is an x-ray from back then. People used to be super proud of an x-ray like this, right? They had a nice inner body in the disc space, good foraminal height, great job, right? But it's completely flat. People didn't recognize the importance of segmental lordosis so much back then, and it was hard to get it with the implants back in the day. So TLIF came on. It was something that you didn't have to do a PLIF. You didn't have to stretch those nerve roots quite so much. So there was some work through there, and it was great. But it was not. It was a good solution for spondylolisthesis with radiculopathy because it treated that. But it led to adjacent segment degeneration because you're flattening out those lumbar segments. And I've always worked through this process. I'm always thinking, how do I get better with what I do? So in the beginning, we used titanium. We used titanium mesh cages, which we used because they worked, but they weren't great. They weren't designed to go in that space. You kind of had to hammer them in there. They were radiopaque, so you couldn't see through them. So you didn't know if you had good fusion or not. And in general, they tended to subside a little bit. People didn't exactly love them, but that's what we started with. PEEK came out, and PEEK was going to be the answer. That was a great thing. Everybody's excited about PEEK. We had these bullet cages. A minimally invasive TLIF became easy to do once you had a PEEK spacer with a bullet that you could oblique into that space. PEEK was great because that has a modulus elasticity similar to bone, so you had less subsidence, and it was radiolucent, so you could see fusion on X-ray, which is still an upside to PEEK. And the bullet-shaped cages went in easily. They're self-distracting, which allowed you to get in a small space. And whether you put that in with that upper corner with a true percutaneous through a little tube or an expandable tube like you see in the lower corner there, there's a variety of different ways to do that, but it's something that's what I was doing. But the problem with PEEK is it's relatively inert. We know it's not very bone friendly. Now there are the porous PEEKs and other surface architectures that are supposed to be better, but back then we knew we'd go back in. If you do a pseudo for a PEEK implant, there was a nice little fibrous capsule around there that was definitely not adhering to the bone. The cages generally weren't lordotic. You're putting in oblique across there, and they sat on the weakest part of the bone. So even though they had good modulus of elasticity, they sat in that central part of the disc. So we were doing it, but not great. My most cited paper when I look up Google Scholar is this one. This was our ALIF versus TLIF paper that Patrick Shea was the lead author on this. We looked at ALIF versus TLIF. And this was first generation minimally invasive TLIF. This wasn't open deformity TLIF. This was minimally invasive TLIF. And lo and behold, and this was ALIFs with threaded cages. It wasn't even modern ALIF technology either. But the ALIF trounced the TLIF in terms of restoration of foraminal height, disc height, change in lordosis and improvement, where TLIF actually, you got nothing. So negative 0.1 degrees. So you essentially left it as is or flattened it out a little bit on that TLIF. So it was good for radiculopathy and single level disease, but not good for alignment, and certainly not a part of something you do for a deformity back then. Well, Chris Shaffrey came out with this paper, and I used to sit through lectures all the time where he would, talk about how they did their great TLIFs and we did our terrible TLIFs. And the truth is, these are open deformity TLIFs that he was doing. And I would sit in the audience and say, well, of course, you're doing it open and you're distracting on the spinous process and doing all of those things. But then I would sit there and think, well, why can't we do better in our minimally invasive TLIFs? What's holding us back in this? And so that sort of sent me on a path to try and do a minimally invasive TLIF for degenerative disease and get the same results that we could get in a deformity TLIF. We can get up to 20 degrees of lordosis in the appropriately selected patient. So I knew I could do it open. Why couldn't I do it MIS? And some of it was technology, some of it was technique, and how would I marry those two and come up with a new strategy to do this better? And it started me kind of on my, what has been my TLIF journey. And our nurses in the OR, I'm sure, aren't a big fan of it, because every few months I'm doing it a little bit differently. And it's still to this day, I still am changing little things all the time. And when they haven't been with me for a while, they come back in and they're like, oh, what did you change? And but it's because I always wanted to be better. So in the beginning, I started taking those MIS TLIFs, and I would take, instead of putting that bullet cage in oblique like you're supposed to, I'd put it in, I'd pound it to the side like a boomerang. So I'd pound it across to the front, try and get it to go side to side, and then do a little compression, and I could get a little bit. So it was better. Still not what I would consider good at this point, but better. So making a little bit of progress. And back in the at this time, I was doing this through what you call an X tube. So a static tube that gives partial expansion. It's a fixed like posterior, but it would open up anteriorly, so you could work through and get, I could put those screws in through that tube essentially and get them to do my TLIF. So it was better, but not good enough. Still not a fan of PEEK. This is when the PEEK was starting to fall out of favor a little bit, where we'd see that it wasn't exactly bone friendly and maybe titanium was better. There were coated PEEKs and other things that were coming out. And again, people are doing better and better with all of those things all of the time. But titanium started to come back in vogue, and you were getting titanium implants that were actual TLIF spacers, not just a mesh cage that you'd put in that. And you get porous surfaces even now that improve that as well. So I switched over to a titanium implant, and I could get a little bit bigger implant. I could get a boomerang style implant, and I could rotate that around to the front, and I could do an even better job. So getting even more lordosis. So getting happier and happier. Here's a 2-level with reasonable lordosis from L4 to S1. It took a lot of work to do that. I would do this through a quadrant tube. So I moved to an expandable tube that I could flare it out and get a little more expansion, so I could get to 2 levels if I needed to. Still, in the beginning, I would actually drop a little tube and look down there and try and freehand the screws. Then I switched over to navigation. I've never been a fluoro user. I don't like using fluoro for anything. I get too hot wearing lead, so I don't use it. But I've started navigating these screws. So I navigate the screws and then do the TLIF through the tube and rotate that titanium spacer into the front and do some compression, which was helpful and better. But still, if this patient started off lordotic, I could just match their lordosis. I'd be good at not losing lordosis. If they were flat to begin with, I'd gain a little bit, but not reproducible in all settings, and a little hard to do. So again, I was getting better and better, but I had to figure out why I couldn't duplicate the spinous process distraction that I use in an open TLIF. When I do an open TLIF, I intentionally do not take down the spinous processes. I'll cut a Smith-Peterson osteotomy. Even if I need to do a big central decompression at the end, I don't do that in the beginning, because I will put a laminar spreader on the spinous process and distract. That is my primary mode of distraction, intradiscal and spinous process based. I will put the little TLIF distractor on screws or a temporary rod on the other side, but I don't like to stress my implants, especially in a short segment fusion. So I will do all the distraction on either the disc or the spinous process and just hold it open with the TLIF. So I'll distract and then give a click or two on the screw-based distraction. So that's what I was trying to figure out. And then I happened upon a system where I could actually mount the retractor to the screws and use some screw-based distraction on there to get a little bit of that to hold, which was helpful. And I thought that was going to be the next step. So I was able to, and technology improved, and full disclosure, I did help design and develop a TLIF cage. I won't tell you which one, but that helps with that, and adding lordosis to the cage is helpful. So I do this is kind of my modern technique, almost my current modern technique. Things that changed here were a little more lordotic implant, a little more ability to distract on the screws, which again, I don't want to overstress them, but I can hold distraction with the screws. And I started using an adjustable bed. That was a little bit of a game changer. So when I do a TLIF, I flex the table into 20 to 30 degrees of kyphosis to start the procedure. I put in the screws, I do the facet release, I do the discectomy, I distract it as much as I can. I put in the cage and then put in the rod, final tighten the bottom screw, and then I flex the table all the way back down into lordosis. And I shorten that rod a little bit in the beginning. I watch that rod rotate through, and then I do a little bit of compression. And when I do that, I really get a lot of lordosis on those. And you can take a pretty flat disc and turn it into You can get nice foraminal height and good lordosis, which I really believe is the key to minimizing adjacent segment degeneration. If you fuse a segment and you leave it hypolordotic, particularly at L4-5 or L5S1, you are really adding to the adjacent segment risk in that patient, even if you do a very nice minimally invasive TLIF. And so some of those, so this was getting a little bit better. So a flat disc becomes a lordotic disc. And in a minimally invasive surgery, adding to lordosis is pretty, is tougher to do than it sounds like, but I could get reproducible results. And here's what most of them look like now. So using, again, a more lordotic implant. And one of the keys here, so we always used to think you push the cage all the way to the front. Lordotic implants have changed my thinking on that. I no longer push the cage all the way to the front. I want it right like that one there. I want it right in the middle. So that's probably a 12 millimeter high implant. But if you look at the front of my disc space, that's probably 14 millimeters high in the front of that disc space. It's very much like doing an ALIF at this point. Because if it's 12 millimeters here, my gap here is much larger. So if you have a lordotic, right, I want to maintain foraminal height. If I push that all the way to the front, I'll have 12 millimeters in the front, but maybe only 4 in the back. If I leave in the middle, I get 14 in the front and maybe 6 or 7 in the back. So I maintain that foraminal height and lordosis is really the key there. Now, the key to this is not having that subside. So picking the right implant, not overstuffing it. So you want it to be elevating that height, but not too big. Really goes a long way and gets reproducible results. So, so my evolution there, quite a bit. I tell people I'm on version like 8.2 of how I do this. I was doing open techniques which are good. I did MIS, which wasn't so good. And now I can do MIS, and I'm actually probably better with the single level MIS than with a single level open these days in terms of what I can achieve. I've changed my retractors from metrics to X-tube to quadrant to now this screw-based distraction. All sorts of different types of cages, now using the 3D printed titanium. And then positioning, when we started doing fusions for TLIFs, because you had to have it open a little, they were on Wilson frames, terrible. Then Jackson frame, which is great for lordosis, hard to get in that disc space. And then the ProAxis table where I flex that into the kyphosis and lordosis has really changed the game. One of the keys though, is when I did that, I went to this screw mounted retractor. So I'm not table mounted anymore. So if you're flexing a table in and out, having a table mounted retractor becomes a problem. So those two things in combination allowed me to really do what I want to do there. And
sorry to interrupt. One more question. Is that okay?
Yeah.
I think like many in the from the participants, you know, we like yourself, we've all gone through different iterations, you know, open, MIS. I mean, I'm still doing it, like you said, almost, I'm changing it constantly just to see what's better in my hands. So one of the things that I've noticed is, you know, after all of these iterations, and I still love the MIS TLIF technique, when I really want that, you know, lordosis, that foraminal height restoration, especially indirectly, I just went full circle back to the ALIF. So you have a lot of experience with the ALIF. What's now that you've been doing a lot of this, what would you say about that? About, you know, when you utilize the ALIF versus one of these TLIF approaches for getting the result that you want?
So great question. I do quite a bit of ALIF as well, and anterior approaches are powerful. So getting to the front, you just have so much more working room in that disc to lift that up. So an ALIF is powerful. You even the best TLIF probably can't match the best ALIF, right? And laterals, you know, for the upper levels can be really helpful to restore that lordosis and height as well. My thoughts are currently, I do a lot of MIS TLIFs for these because I can get so much height restoration and lordosis correction. So if I can do a standalone ALIF, so really not a spondy, but something that's lost foraminal height and I want to lift that up, I will do a standalone ALIF because I'm not touching the posterior spine. And I think there's something to be said if you can do it standalone, not have to touch the musculature. If I'm doing I do ALIFs for pseudoarthrosis, I do ALIFs for deformity where particularly somebody's had a posterior, I see a lot of people that have had an attempt at a deformity correction, pseudoed and haloed out their sacral screws and it's all blown out and it's collapsed. And I know I've got laxity down there. I restore height with ALIF in that because they've already had a posterior approach. Somebody that's got a degen spondy, it is 95% TLIF for me because I know I can get there and reproduce that. And in that case, when I would do an ALIF, I would do the ALIF and then I'd usually put some perk screws in through the back. And if I'm doing the perk screws, it's the difference between this and this for me in terms of incision and muscle dissection to just do the TLIF. And I'm just faster to do that, right? I can have that done in 2 hours versus the ALIF and the flip. And, I know people do single position and everything else, but it just adds time to do that. At least in my hands, I'm faster doing a TLIF. So that's where I have switched to doing that. And then in an ALIF, right, I was using BMP and in that sort of in the spacer like you're supposed to. I don't use BMP in my TLIFs because I put the perk pin into the pelvis and I go down, I get a little bit of bone marrow, aspirate, and then I will actually take a pituitary and just grab a few bites of iliac crest to fill that. And the fusion rate on that is great. So I don't worry about heterotopic ossification or all those other things. So, so as I've gotten better with TLIF, I've done fewer ALIFs in this scenario, but ALIF is a technique that is still critically important in my practice. And I still use it in a variety of ways. Like everything, things go through cycles where something goes awry or is difficult in a TLIF, or you really struggle someday, and then like you start doing a few more ALIFs, and then somebody gets into a little bleeding in iliac, or you get a DVT, and maybe I shy away from ALIF, right? So the pendulum swings a little bit, but and we always get our recent experience colors our decision making a little bit in the clinic, but I get good results with TLIF now that I'm satisfied with, so I'm doing fewer ALIFs for that perspective. My pendulum swung where we were doing TLIFs and I didn't love them, so I was doing a lot of ALIFs, and then I've gotten better with TLIFs, and I'm doing that. And quite honestly, watching other people do better with ALIF and watching people do laterals and do really well has improved my TLIF technique. Right? It pushed me to have to do better to try and say, what can I do with that? So that's been a part of it. Nader asked me to give this talk about a month ago, so I just started snapping intra-op photos of my MIS TLIFs over the last month. So these are the ones I've been doing, and it's pretty reproducible, right? The average cage I put in is probably 12 millimeters tall. Anywhere from 11 to even 14 is the tallest it gets. I have stopped putting in various degrees of implants. I use 10-degree implants at L4-5 much more often now. I was using 20 degrees. I used 20 degrees at L5S1. I was using 20 at 4-5, but that leading edge on the more lordotic, if the disc is really lordotic to begin with, I'll use a 20. But otherwise I use a 10. And I'm undersizing more than I used to because I think you get a little subsidence on that leading edge if you try and force it too much. So that's my latest iteration, is I've actually dialed back how aggressive I am with it a little bit, and I get better long-term results. Might not look quite as good intra, but it looks better in the long term. So again, that technique is just a series of steps. So my first goal when I get in there, I'm trying to improve disc height. I'm usually doing a TLIF because I want decompression and improve foraminal height. So first I get into improve disc height, and then I do everything I can at the end to get the lordosis. So by improving disc height, that's flexing them into kyphosis to start with. That's putting in my screws before I do my inner body, because I want to be able to distract everything before I put that inner body in. So I know a lot of people with an MIS technique, there's a technique where you do the facetectomy, put the cage in first and then put your screws in. You lost all ability to sort of distract and do anything that way. So I do it the opposite. I put the screws in, use them to distract and do that. I do a posterior column osteotomy on the majority of my TLIFs, unless they have a tall disc to start with and don't need any foraminal decompression on the other side. Even then, I have like the fellow just even usually pop off that inferior facet just so I've got a little ability to compress and distract. I use inner body distraction with a distractor in the, you can dial it up and sort of like jack open that disc space, place a lordotic cage, try and get it again in that middle to anterior third of that disc space, then flexing into lordosis, and then finally screw compression. So screw distraction and screw compression are the minor parts of my correction, because I'm trying to, again, I want to minimize the strain on those implants up front, and I think you get less screw loosening that way.
Dr. Koski, there's a question here in the chat room. A question was, if I want to continue doing interbody cage placement, I would suppose, with the tube first, what's the best interbody and or technique to retain lordosis?
So if you want to put the cage first, you have to get that disc space distracted. So I would tell you, if you're doing that unilaterally, it's really hard. If you said that, hey, I have to put the cage in first, that's the technique that I have to do, I would drop a tube on both sides and loosen the facet on both sides first. I'd try and still do it on a table where I had it in some kyphosis, and I would try and distract that disc space. You're going to lose the ability to hold the distraction open with the pedicle screws, but just like in an ALIF, you put that first trial in there and it starts to pop open, and it sinks back a little bit, but it never sinks all the way back, so you get some. So I keep working in that disc space to distract that and try and get that to stay open, which I think you could do, and then put that spacer in, and then make sure you can do some compression at the end.
Okay. Do you have any opinion on expandable TLIF cages?
If it works in your hands, great. So I had a brief aside where I tried some of those. I saw a little subsidence more than I wanted to, so it looked good in the OR, but I lost a little bit of that. So I'm more of a, like the cages I put in are 35 long, so they're pretty long inner body, so I get a lot of surface area, and I was missing that, so that's why I went back. I think the technology in that has improved as well. I've been on a little bit of a different path, but I see great results, and people have shown me with the expandable. So if you have an expandable that works well in your hands, the key is not to overexpand it and start to drive it into that end plate, because once you get subsidence, you lose a lot of your correction. You're better off with a little less correction and no subsidence than great correction and subsidence.
One more question, Dr. Koski here from BC. She thanks you for this talk, and then her question is, how do you find the balance between restoring good disc height and lordosis without overstretching the nerve with a large cage?
Yeah, that's something. So I did one today. It was a deformity, but I stretched it open, a completely collapsed disc, and I actually feel that it's not the exiting nerve, it's the traversing nerve. I actually feel that to see, and it was starting to get on a little tension, and I said, that's all I can do. Now I took a disc that was completely bone on bone, where I couldn't put I couldn't get a 15 blade in to start without distracting on it a little bit, and I put an 11 tall cage in there. But that was all that I thought that nerve could take. So I feel that traversing nerve. That's what I do, and I check that every time. So moving on a little bit. So I like doing degenerative surgery. I do a lot of MIS TLIFs, but I'm really a deformity guy. So I believe that the better you do with degenerative treatment, the less revisions and less deformity operations we do. And I take the same approach in trying to do deformities where I get better long-term outcomes and reduce complications by, again, just continual advancement and improvements in what we do. So adult deformity, what I consider adult deformity: scoliosis, kyphosis, sagittal imbalance, and high-grade spondy. People will count degen spondy because it's a spondylolisthesis as on deformity numbers. I don't personally count those, but so that's what, when I say deformity, that's what I'm talking about. So the reason we have to get better in deformity surgery is because the complication rates are high. So if you look at some of the historical data, it's pretty striking. This was a national implantation sample database query looking just for complications, and we know that data, when you look back retrospectively, probably misses a lot. This is primary and revision adult deformity, but 47% complication rate versus 72% in the revision cases. So if you think those numbers are likely underreported, those are pretty high. This was an interesting paper that I really liked out of Vancouver. The group up in Toronto did a cool paper where they did a 12-month prospective registry of their spine patients. They looked at 942 patients with complete data. All of these getting complex instrumented spine surgeries. Only 58% elective, so there are quite a bit of trauma and urgent cases in here, but they looked at their complication rate, simply looking at complications. So they took the year before, same population, same hospital, and they noted a 23% complication rate when they retrospectively analyzed it. When they did it prospectively, they had an 87% complication rate. So the difference between retrospective and prospective is well on display there. But they had 14 mortalities, 14% intraoperative adverse events, and we all know that intraoperative adverse events are what kind of keep us up at night and take years off our lives. Neurologic deterioration in deformity patients, so 5.3%, so significant, which some of studies have borne out, and dural tear, 4.5%, which is pretty much right on with the literature. We did a study that this was the adults symptomatic lumbar scoliosis NIH-sponsored trial that came out, and this is the results that were published last year. This is the intention to treat. So if you look at the dark line is the operative patients, the dashed line is the non-operative patients. You can see the surgical patients did much better initially, and then those lines start to come together a little bit. I'll tell you right now, those lines come together because of crossover. If you look at the as treated, you can see the surgery versus non-surgery dramatically different. So we know that surgery for adults with scoliosis and spinal deformities is really impactful in terms of function and disability. But we know the complication rate is high and the cost is high. So we need to do better at getting these patients, getting this outcome with lower complication rates. And that's what we've been working on. So and incremental advances, we need to get better. We need to get faster. The faster you are, the less blood you lose, the lower your complication rate, guaranteed. Now you can't be sloppy and just hurrying through. You need to be efficient and do a good job and be meticulous. But we know that leads to fewer complications. We have lower revision rates if we do a good job, right? Infections, PJK and PJF, and pseudoarthrosis. Those are the big three in terms of why people need revision surgery after deformity operations. If we can lower our revision rate, we lower our cost and improve our outcomes significantly. And reducing medical complications is something that at Northwestern we've been on a mission for that for a long time now. So this is a paper that we did that was a cost minimization and treatment of adult degenerative scoliosis. So this was essentially looking at Rick Fessler's MIS cases versus my open cases back. I mean, these are probably patients from almost a decade ago. The study results were the MIS patients had shorter length of stay and a lower cost, by quite a bit lower cost. The open had better alignment and better functional outcomes. So if you think about it, it was, right, the long-term functional outcomes were better in the open surgery, but the cost was higher. And the question was always, was that worth it? Well, I looked at this and I looked at the cost and I said, well, what are we doing here? It was all ICU stay, and did patients stay on ventilators and things like that. So I took this as a mission to, like, well, we have to do better. I have to reduce my length of stay. I have to reduce my ICU stay, and I need to reduce my cost, or people are going to say, hey, you should do these MIS, even if you don't get the same alignment and outcomes. And the MIS group should be saying, well, how do I get the open level alignment and outcomes and maintain that same differential? I mean, truthfully, we want patients to do better. And whether you do it MIS or open, like, I do things both ways. I want to pick the best operation for that patient. But I knew from an open standpoint that I needed to be faster and better and get the patients out of the hospital earlier to make this a viable long-term treatment strategy for them. Here's a patient from just this past year, 68, back and leg pain. This is an adult idiopathic curve. So this is stuck. This is a stiff curve, needed multiple posterior column osteotomies to release that. But that's her post-op film. Took 6 hours, so not super short, but not very long for that length of surgery with osteotomies at every level. She lost 750 cc's of blood. I did the same operation today, and I did it faster with 500 cc's, so still getting better. But she spent 1 night in the ICU and 4 days in the hospital and was home with home PT, no rehab. So if you put this person into that study we did before, this would have trumped everything, right? So this was shorter than those MIS where patients were staying and needed less adjunctive therapies. So so we can do that with open procedures and get good long-term durable outcomes. Part of the subgroup of that, the scoliosis study looked at significant adverse events. And this was an interesting paper that looked at things like PJK, PJF, pseudoarthrosis, and major medical complications, and the risk of motor deficit in some of these patients, which if you prospectively study these patients, you find some motor deficits in patients after major deformity corrections at a higher rate than you would have guessed before we do something like this. And the Scoliosis risk trial was another one that showed that, you know, you can have double-digit % decline in motor function in some of these patients in that early perioperative period. But anyways, you look through this found that having these adverse events did impact their long-term outcomes. There was always a claim that, well, if you have a complication in a deformity patient, it really doesn't impact their long-term outcomes. Well, this study said, well, it really does. Those patients don't do as well in the long run. So avoiding them not only has the short-term and cost benefit, but it has the long-term impact on these patients. So we want to really pay attention to those complications and do our best job there. So this is a 78-year-old that had surgery just 4 years ago. Now, if you look at this is not modern spine surgery. So this was, right, cylindrical cages, anterior, posterior, lumbar pedicle screws, but some hooks. And right, it's a significant proximal junctional failure. This person has lots of pain, implants pulling out. And if you look up at the top there, you probably can't see here, but those hooks are protruding into the skin and almost coming through. So this is a significant problem. Now, when I show this to people, what would you do? People start thinking, oh, you know, extension up to maybe the cervical spine, vertebral column resection, all of those things. Well, we know that's a pretty morbid surgery. To redo all this, do a vertebral column resection is a really big deal if you study it carefully and look at that. So I did this. So extension up, I did 4 posterior column osteotomies. A posterior column osteotomy takes a few minutes to do as opposed to a VCR, loses a little bit of blood. I didn't go into the cervical spine. I was able to stop at that proximal thoracic spine. as a 500 cc blood loss, no transfusion. Plastic surgery did a closure, which took, obviously it takes a long time for them to do that because again, these implants were coming through the skin. They made this lady stay on bed rest for 5 days. After we let her get up, she spent one more day in the hospital and went home. If we can do that in our deformity patients, then we're really advancing the ball, I think. So, and I like doing 3-column osteotomies. They're the cool thing to do, right? Everybody talks about doing them. They make for really impressive x-rays, but it's way more impressive in my mind to show an x-ray where we didn't need to do one and got the same result as to show one where you did. And I only do 3-column osteotomies now in patients that have a fused spine with immobile discs. So this lady was fused through some of those segments, but the discs were not fused anteriorly. So I can cut through the fusion mass just as easily as I can cut through a facet and begin to mobilize that and get that level of correction. So again, why no VCR?
Quick question.
Yeah.
Technology also evolved. What do you think the impact of using TXA as well as the Aquamantis in minimizing blood loss and improving efficiency too? Because sometimes they have a bleeder, you got to find it. But with the Aquamantis and TXA, I think, do you think they have an impact on blood losses?
It absolutely does. So I can tell a difference. We have a protocol with a low dose versus high dose. I can tell who gets high dose versus low dose when we're working. The low dose doesn't do very much. The high dose makes a difference. So TXA absolutely is helpful. Being meticulous with hemostasis. So areas you lose blood where you don't really need to, exposure, right? So being careful in coagulating vessels when you get bleeding on exposure, that's just, if it just oozes the whole case, that adds to your numbers quite a bit. Pedicle screw placement. So every time you go into the pedicle screw tract, right, you can bleed out of there. So putting something in there to stop that each time matters. So each step of the way, trying to reduce that blood loss makes a big difference over time. So again, 3-column osteotomy, if you need it, yes. If you can avoid it, you're better off avoiding it for many reasons. So when we think about avoiding some of these complications, I always think, well, when do they occur? It's either intraoperative or postoperative, but a lot of the intraoperative and postoperative problems start with poor planning up front. So that's where that preoperative evaluation is so important. If you look at this film, this is something that was just lost. This is not I didn't do the first surgery. I did the revision on this, but when you can put a screw straight through the S1 nerve, that's a pretty bad shot. So preoperative inadequate assessment alignment, not setting goals or not achieving them, not getting patients medically optimized and spending the time to do that, and inadequate evaluation of bone health. So many patients come through and they've had a fusion down to the sacrum and the sacral screws look like that. That is difficult to fix. There's no S1 to fixate to anymore. So figuring that out is something that we all tend to have to struggle with more often than we'd like to. So intraoperative poor positioning is key. This is a modern picture of somebody like, hey, look at our great spine frame. Not so great if you're doing a fusion operation, right? That is a recipe for a flat back. But just like you talked about, not a poor hemostasis, poor tissue handling. So being rough on the tissue, leaving retractors on for too long, getting to necrosis of that muscle leads to infection risk. Then putting implants in the wrong position, however you do that, dural tears, spinal cord, nerve manipulation, all is really, the big intraoperative things. Postoperative, inadequate VTE prevention is a big one. So that is, an initiative and an effort that's looked at more and more closely every year. Every one of my patients gets low molecular weight heparin. I do Lovenox on postoperative day number 1, unless they have some contraindication. But I do post-op day 1 and have yet to have a concern for that. But inadequate nutrition is key. We really need to avoid that, and that's easy because patients don't have good appetites after some of these. Poor wound and drain management, drains getting disconnected, things like that. We have a protocol for all of those things. And then lack of supportive services. So making sure the patient has good support for when they go home is really, really key. So when we talk about reducing these complications, you got to figure out what can you do something about, and then do something about it. Some things are unmodifiable, right? If somebody is old, they're old. You can't fix it. But if they're malnourished, you can get them a nutrition consult. So things that we can modify up front, I think patient selection is key. So smoking status, mental health is we don't think about it enough still, even though everybody knows it's important now. Bone health is key, obesity and nutritional status. We do MRSA decolonization, and then good surgical planning on how you're going to do that operation. We have preoperative guidelines. These are our infection prevention guidelines that all patients are supposed to meet unless they have an emergency or urgent surgery. So for the deformities, it's hemoglobin more than 11. Doesn't necessarily apply to some of the others, but BMI under 35, vitamin D levels more than 30, hemoglobin A1C less than 7.5, Albumin greater than 3.5 is not a great measure. Our nutritionists don't think that's great, but it's a screen to at least flag somebody for a further nutrition screen. They pass a urine nicotine test. They need to be medically optimized, and our preoperative clinic now does frailty and nutrition screening on these patients. And we need to, react to those screens if we have negative results. Intraoperatively, again, minimizing blood loss. I can't say it enough. Minimizing your durotomy, so being very meticulous around the dura. A durotomy is going to add to your surgical time, add to your wound healing complications, and add to your blood loss as those epidural vessels start to bleed. And then protecting the neural elements and being very careful with what you do and making sure you accomplished your goals. Again, deformity starts with fixation. So here's a patient with a neuromuscular curve that was pretty rotated. Are you going to put in screws, or what are you going to put in? But you need to be able to put those implants in safely, efficiently, and effectively. That's that right L2 pedicle on that patient. And if you look here, this is from about 10 years ago, but this is that screw going into that pedicle. And if you look at that angle, like that should be going through the canal in a normal patient, but it's a deformity, is rotated. That's where that screw has to go. All right, so you can see where that screw goes. And if you look, that's that screw going down that pedicle. Now, those are all placed freehand. You need to be able to place screws in pedicles like that efficiently to really do deformity in an efficient and effective manner, whether that's freehand or you're really good at fluoro or nav or robots or whatever you do, it has to be efficient and effective. And then you can pull it around if you get good fixation to do something like that. So we all know the alignment goals. I'm not going to belabor that, but you need to be able to check. So we do either intraoperative long segment Scoli films, or now I stitch O-arm films into a long segment film. And I personally scrub out and measure every x-ray before we move the case forward, every single one without fail. I learned the hard way early on where it looked pretty good. And then when I measured, I wasn't happy with it. And you get one chance to fix it, and it's when you're in there. So I personally scrub out and measure every x-ray. So again, post-operatively, get your medicine team involved. And I don't want to belabor this, but the Northwestern high-risk spine protocol is something we did in 2005 that really, in my mind, kind of another game changer that in terms of medical workup. And I know that's really taken root across the country. People are doing excellent work. Raj Sethi in Seattle took this and has run with it and done amazing work on that. But trying to get a uniform pathway, preoperative, intraoperative, postoperative patients started in 2005 at our institution after an intraoperative death on a young patient that due to a transfusion reaction that I thought was preventable with the appropriate workup. So our high risk case, it's if they're more than 6 levels or more than 6 hours of surgery, if they're anterior, posterior, if they're staged, or the age is greater than 80. Those are the criteria that automatically trigger an evaluation as a high risk spine patient. We started this in 2007. Again, this is in the literature, you don't need to belabor it, but you can see we have a lot of different things, preoperative pathways, preoperative testing that we do, intraoperative communication, what gets written down and documented, our various lab guidelines, temperature guidelines, transfusion guidelines, and then postoperative care and communication, what labs we check and when, all protocolized, which it allows us to stay on that protocol. So we published it in 2007. We did a looking at how well are we doing with it. And we had, during this time period, more than 30 attending anesthesiologists. Now we have about 6 neurospine anesthetists that work with us, but over 100 residents in CRNAs. And we only had a 2.6% protocol breach with a fairly robust protocol. So it meant it was easy to follow. It made sense. But we've looked at cardiac events, which has driven our practice. But we've seen significant improvements. My patients don't stay in the ICU anymore. They rarely stay intubated. It's probably 98% extubation post-op after a major deformity. And so when I think about deformity and reducing complications, right, you have to have solid indications. For me, it's pain resistant to non-surgical management, neurologic deficit due to deformity, and radiographic progression. That's it. That's why I do deformity operations. Curve magnitude is not a factor in adults in my practice. That's for adolescents only. I don't think that applies to adults. Is a patient medically and socially appropriate for surgery? Can they heal the operation? Do they understand the stiffness that's going to come from that? Because if they don't, they won't be happy. And do they really understand the risks? If you can answer all those questions, then those patients do really well with a well-performed deformity operation. So how much do you need to fuse is a whole nother talk. Having a PJK prevention strategy is a whole nother talk, but very important in the deformity world. And we've done significant work in that and really made huge strides in reducing that complication. And when do I say no on these patients? I believe if you can't do the right operation, don't do an operation. People say, well, I can't really do the big one, but maybe if we could just do something small and clean it up. Resist that urge. That usually ends up with the patient worse off than they started. And then you end up looking at doing a big operation on a person that you didn't think was a candidate the first time. And that's a rough spot to be in. If the medical risk is too great, you're just asking for trouble. If the surgical risk is too great, and don't forget about the patient's psychological comorbidities. If they don't have appropriate psychosocial framework and structure with themselves and with their support system to get through this operation, they'll never be happy with it. Like, you could do a great operation and they just won't do well. So you really need to get them some help on that front before you move forward. So, and what leads to growth, right? Don't be satisfied with what you're doing now. Always strive for better. Think about it all the time. How can I do this better? Sort of do a debrief on all of your cases. What went well? What could have gone better? How could I change that in the future? But the fact that you're on this conference and listening to me, drone on for an hour, is right. That's a desire to be better, and that's great. But doing research and interacting with engineers in industry, which I do, I find really useful because they think differently, and you understand a lot more about what you do if you understand the engineering behind it. And then really evaluate your techniques and result. Look back at what you've done, think where you can improve. And again, we always need to think about, can we reduce our cost? Because that's something we're judged on, whether you know it or not. But we're getting judged on that more and more as we go. So in conclusion, I know I rushed through that at the end there. Big steps occur, and hopefully all of you will come up with some major game-changing, paradigm-shifting changes. But it's the incremental advances that we can do on a daily basis that really make a big difference for our patients as well. We need to work on both, and find your niche. Find what's good for you. Whether that's, are you a single position surgery person and you want to grow that? Are you into the robotics? There's so many things that people do now that there's room for growth, because those technologies are still in their infancy. They're good, but not great. And there's room for advancement. So find where you fit in that, and add to the knowledge base and advance the field. So, and with that, thank you.
Thank you so much, Dr. Koski, for an inspirational talk. No cutting corners, becoming efficient, thinking about each case, dreaming about those cases before you go, and constant self-reflection and assessment. There's one of our friends, Dr. Michael Galgano, has a question. I asked it a few minutes ago. Can you comment on interbody choice, if any, when you have a patient with multi-level lateral listhesis in conjunction with sagittal imbalance?
Sure. Multi-level lateral listhesis. So I oftentimes, I'm a posterior guy, so I'll do like all posterior on that. I tend to not interbody those levels with the lateral listhesis. Now, if you can lift that up, you can kind of get a little parallelogram effect, where if you can expand the height, it comes back a little bit. But I cut a posterior column osteotomies and release that. And I do generally what's you call it considered translation derotation maneuver, whether that's reduction screws or reduction towers. And I go on the concavity of the lumbar curve, and I actually pull those levels over to the rod after I've sort of flexed the table into what I think is the right lordotic position, which tends to work really well in that scenario. If I wanted to really place an inner body there, I might actually either wait and do it after I put that rod in there, just because if I feel like I need it for fusion or something, or I'd intentionally undersize that so I could still slide that a little bit, because you do risk blocking yourself a little bit. If you put a big inner body in there and it hasn't reduced, now it gets hard to pull that across.
Okay, that's beautiful. Thank you so much, Dr. Koski, for a great lecture. Next week's topic will be announced. Dr. Baj, if you want to make a comment. So will be announced pretty soon, and it's gonna be a nice surprise. So stay tuned. I wish everyone a great evening, and thank you for joining us for another session with Virtual Global Spine Conference.
Great. Thank you, everyone.
Thank you all.
Thank you. Bye-bye.